So if you say we shall start with the session, and in the meantime, our faculties will be joining.
Yeah, we can start with the speakers who have joined.
And so before that, sir, I would request your permission to just share some insights about Translumina. What is it all about?
Yeah, fine. But I think Pranay and Raja, they're. I think are they with us?
Yes, sir. Dr. Pranay sir and Dr. Raja sir have already joined.
Okay, fine.
So shall we start? Dr. Pranay sir and Dr. Raja sir, if you both are there, so if we can start.
Yeah, please.
Thank you, sir. So I'll just share up my screen. So hope my screen is visible.
Yeah, it's visible. Yeah.
So, good evening to all our faculty members, and thank you for joining the DEB Talks, that is basically on the drug-coated balloons. So, before we start, I would just like to take few minutes of yours to share what Translumina is all about. And just to start about exploring limitless possibilities, Translumina has been bifurcated under Integris Meditech, India's leading diversified medtech platform for global emerging markets, wherein Everlife is one of the segment with leading lab and analytical equipments platform in Southeast Asia, and also in Translumina, which we are talking about, a leading cardiovascular solutions provider in emerging Asia and Europe market. So under Translumina, we have LAMID and Blue Medical devices as well. And talking about an overview of Integris MedTech, which is India's leading diversified MedTech platform. So cardiovascular, in vitro diagnostics and scientific lab solutions are there, wherein leading market position as the number one player in largest stents player in the market, positioning at number two. And 18% of the market share has been taken by the Integris MedTech in coronary stents in India. And unparalleled market access with 2,000 plus hospitals and cath labs directly covered, wherein 17,000 plus laboratories were covered, and with distribution partners of 350 plus within 60 plus countries. So talking about our strong R&D and manufacturing units, we have been manufacturing 100 plus SKUs with 7 market manufacturing centers in India and Europe, and wherein 2 R&D centers are there. So this is our segment, which is under cardiovascular polymer-free stents, advanced coronary DCB, calcium modification technologies are there like OPN and IVL, intravascular imaging and physiology solutions, and vascular accessories. And under in vitro diagnostics, immunodiagnostics, clinical chemistry, hematology, molecular diagnostics, and other clinical diagnostics. So in our in-house manufacturing has robust research and development and manufacturing capabilities, plus our tech transfer, distribution, and supply partnerships with large MNCs such as Shockwave, Assist, Sys Medical, Hemonetics, Kanika, Asahi, and many more. So to deep dive in Translumina, this is something that Translumina has, which has taken a position of second largest stents player in India, and with 17,000 plus stents per month, with 18% of the share in the market. And the 2,000 plus physicians have experienced their hands over the stents with 1,000 plus cath labs, and 120 plus distributors with 100 plus sales team members are associated with Translumina. So with a global presence and strong clinical pedigree, our distribution network is in 50 plus countries, and wherein in our international markets, 20 plus sales members are associated with us. And our diversified manufacturing with 5 manufacturing facilities across India, Germany, and Netherlands. So this is our comprehensive product portfolio. And recently, Translumina has further strengthened its technology portfolio with acquisition of Blue Medical Devices that is based out of Netherlands. So the acquisition has basically given an access to a patented, innovative, and proven next-generation drug-coated balloons technology. That is Protege. Protege is a paclitaxel-coated coronary balloon dilatation catheter, which is EU MDR certified and has its global presence in more than 35 countries. And its R&D and manufacturing lies out of Netherlands, with EU MDR certified approval and patented drug application process. So, talking about Protege, Protege has been powered with three unique, basically, applications. The technology which says the very first is unique drug coating application process, which has minimal drug loss during the transition. And the second is wing seal technology, which has corrugation over the surface of the balloon, which makes the balloon low profile and for better trackability, crossability, and better flexibility. And just because of the drug has been secured so nicely and so tightly, there is a possibility for multiple inflations. That means three inflations with the same device within the same vessel is possible. And Protege is the very first and the world's only balloon available in NC version also globally. So again, I would just like to take a moment to thank all of our faculty members today for the drug-coated balloons in era of modern PCI webinars named as DEB Talks. Thank you, Dr. Sumit Dhi, sir, our senior consultant interventional cardiologist in Narayana Health, Gujarat. So thank you so much, sir. Over to you.
Yeah, thank you, Garima. So, welcome to everybody. I think three speakers out of five have already joined. So, we'll be starting the session with the speakers who are already with us. Good evening, everyone. Thanks, Dr. Pranay. Thanks, Dr. Raja. And thanks, Dr. Preeti, for joining on time. And I really like the name what Translumina has given, the DEB Talks. It reminds me of TED Talks. Basically, I think it was inspired from TED Talks, which I think we all listen to very regularly. So very fine, fancy name, and I think it does deserve this kind of fancy name because drug coated balloon is something which has come up. I would not say very recently, but it's something which has given us a new dimension because we as interventional cardiologists are used to putting stents now. Everywhere we are just putting metal jackets wherever we feel, slightly threatened, like, there is some kind of residual stenosis, some kind of dissection disease, which is, which we are not very comfortable with unstable plug, we tend to put a stent. Now, putting a stent has got its own problems. Metal jackets, they do, give us that fear of stent thrombosis, uh, giving very strong antiplatelets for a longer period of time, which may be a problem in certain patients. Uh, there is always a stress of good amount of post dilatation after the stents, so that we don't have incidence of stent thrombosis or instant restenosis, patients coming back with repeated lesions, repeated revascularizations. So these are the problems which we face when we put stents. Now, all those stents have stood their test of time, and now we have fantastic stents available with us. We have good post dilatation balloons, imaging facilities which have made stent deployment relatively easy, more effective, with fantastic short-term and long-term outcomes. But I think there is a place for drug-eluting balloons also, or drug-coated balloons also, because especially in the Asian population, we have, smaller statured people, longer history of diabetes, small vessels, diffuse disease, I think, in which we are all not very comfortable putting multiple stents for the very same reason that increased incidence of stent thrombosis and restenosis. So I think there is a niche area for drug delivery balloons now, and we are here to discuss some of those areas where drug eluting or the drug delivery balloons are equally capable as stents, and where we are very, very comfortable or would be comfortable in future using drug coated balloons instead of drug eluting stents. So we have speakers today. I think Dr. Leela has also joined. Welcome. So we'll be starting with Dr. Leela, who is interventional cardiologist at Omni Hospital, Telangana. We have people from all over the country today joining in. That's very nice. Then we have Dr. Raja Nag, who is interventional cardiologist at Manipal Hospital, West Bengal. Welcome, Dr. Raja. Then we have Dr. Gore, Dr. Pranay Gore, who is from KIMS Sunshine Hospital, Telangana again. We have Dr. Nirmal Shah from my own town, Ahmedabad, Gujarat, who has, I think, not joined now. And Dr. Preeti Sharma from Department of Cardiac Sciences, Max Healthcare, Uttarakhand. So welcome, everyone. And I think without any more delay, we'll be starting with the first case, which is, just let me try to read, which is lesion preparation for DCB, ideal tools, with a case presentation to be presented by Dr. Leela. I think lesion preparation is one of the most basic requisites required for using a drug-coated balloon. And I think no amount of emphasis is less if we talk about lesion preparation before we try to use a drug-coated balloon. So over to Dr. Leela for your presentation.
Good good evening, everyone. Can, can you see my screen, sir?
Dr. Leela sir, the screen is visible, but if it is possible, if you can just put it on slideshow.
Yeah, enlarge the screen, please. I think go on your PPT, you will see something in the right lower corner.
See, on top there is a play button mode. You can press that. I think he is
Yeah.
playing Mac. Yeah.
Yeah,
Yes.
yeah, better. Yeah, perfect.
I am Dr. Leela Krishna from Omni Hospital, Kottapet, Hyderabad. So the best practices for coronary drug-coated balloon angioplasty, step-by-step approach. Coronary drug-coated balloon angioplasty is a valuable technique for treating coronary artery disease, particularly for ISRs and certain de novo lesions. Here, I am going to tell a step-by-step approach of incorporating best practices. So first thing is the main thing before starting using a drug-coated balloon is lesion preparation. The optimize the lesion for effective drug delivery and minimize the need for a bailout stenting method. Initial dilatation, use semi-compliant or a non-compliant balloon with a 1:1 balloon to vessel diameter ratio. And for difficult lesions, either a non-compliant or a cutting or a scoring balloon or rotational atherectomy or an intravascular lithotripsy or advanced technique to achieve optimal block modification should be done before using a drug-coated balloon. Assess lesion preparation. Confirm the pre-dilatation balloon is fully inflated and there should not be any residual. Aim for the residual stenosis less than 30% and ensure TIMI-3 flow. TIMI-3 flow before using a drug-coated balloon. Exclude flow limitation dissections. Small dissections can be even small dissections can be used. Type A and B can be after that also can use a drug-coated balloon. Whereas a flow limitation balloon, better to use a stent than drug-coated balloon. So, so after using an optimal lesion preparation with the aim of best angioplasty, then use a drug-coated balloon and result assessment after the lesion preparation. It's crucial to decide whether to proceed with the drug-coated balloon or option for stent. Reason for stenting is any significant recoil of greater than 30% residual stenosis or flow limiting dissections type C or signs of ischemia, chest pain and ECG changes, you should do a bailout stenting. Optional functional assessment. If the angiographic result is unclear, FFR may be used to guide the decision. With FFR greater than 0.8, generally suggests suitable for the drug-coated balloon. Drug-coated balloon angioplasty primarily for the drug delivery, not for the lesion dilatation. Drug-coated balloon handling. Handle the drug-coated balloon carefully, avoiding contact with the balloon surface to prevent the drug loss, and position at least 2 to 3 mm proximal to that of cover the lesion. Along with that of 2 to 3 mm proximal to that of the lesion can be covered in the target vessel. And inflation should be up to 60 seconds and with a nominal pressure, and drug delivery time ideally within 2 minutes of vascular access, as prolonged exposure to the aqueous environment or insufficient contact time can compromise drug delivery and increase the risk of target lesion failure. Avoid post dilatation. Drug coated balloon should be the final device whenever you are using a drug coated balloon. Don't post dilate after drug coated balloon. Check for complications, any flow limiting dissections, recoil, or any signs of an inadequate result. Manage complications. Any dissections of type A and B are often not flow limiting and may not require intervention. However, type C or higher dissections require stent implantation. And bailout stenting, if there is a significant recoil or flow limiting dissections, drug-coated angioplasty as a bailout, you can use the drug-eluting stents. And non-flow limiting dissections, close observation and follow-up are typically recommended. Specific scenarios like drug-coated balloon are used or bifurcation lesions, diffuse long lesions, and CTOs. And drug-coated, the approach will be like try to optimize the result before using the drug-coated balloon. Acceptable angiographic and can be used. So even in acute MI, if there is a high thrombus burden, can use an thrombus aspiration and try optimal lesion preparation. Then acceptable result. You can use drug-coated balloon. If there is no acceptable and there is a residual lesion greater than that, use the drug-eluting stent. So this is a case. Years old male with a calcified lesion in the RCA. So this is a diffuse disease in the RCA. He had an intertrochanteric fracture, and they have done surgery. During post surgery, he went into heart failure, and he was intubated and extubated. After that, we took the case. After stabilizing the patient, we took the case. So we passed the wire, and it was a fully calcified vessel, and even the IVUS was not inside. We took a guideliner. With the guideliner support, we did stent. So here there is a dissection with our stent. Actually, here we have used drug-coated balloon only when the place their stent was not going. So we used a drug-coated balloon here. So this is the final result. So after the stent, there was a minor dissection actually. And there is a lesion, we pre-dilated it before putting the stent. And we used a drug-coated balloon.
Okay, Krishna, did you do any kind of
Yes.
rotablation or IVL before putting the stent in the RCA, since there's a lot of calcification there?
We used IVL, sir, before putting the stent.
Okay.
After IVL also, because through the stents, it was not going. The stent was not crossing through the stents. So
Basically,
with two wires, we
drug-coated
tried.
balloon here was for the distal dissection which you had, and you didn't want to put a
Yeah.
second stent.
Yes, sir.
Okay, fine. See, basically, if you, as you said, if you have minor dissections like, maybe grade 1, grade B, with no dye staining, no chest pain, no hemodynamic compromise, no ECG changes, you can very well do a low pressure, ballooning. The vessel diameter does not matter, even if it's a 3.5 millimeter diameter vessel. And if you have a distal dissection, which is not very life threatening, and you have a residual lesion, you can always do a drug coated balloon there. Only thing to remember is that you should wait always after you have done a balloon dilatation. You should always wait for a couple of minutes to see whether there is any kind of vessel closure, any kind of dissection which you may have missed initially. So always after you do a balloon dilatation with a drug coated balloon, I think always wait for a couple of minutes, keep the patient on table, do a repeat shoot, see whether there is any flow compromise. Because sometimes you may have to, as you said, if there is a flow compromise less than TIMI 3, or there is some kind of dye staining because of some micro dissections, you may have to put another stent. So it's always prudent after you have done a balloon dilation to wait a couple of minutes on table, let the patient settle, take a repeat shoot. If you are satisfied after a couple of minutes that the flow is TIMI 3, and if you're satisfied there is no significant dissections, then you can very well ship the patient out. Anyone wants to add anything, or should we move to the next case? Okay. So the next case would be now by Dr. Raja Nag from West Bengal, who will be presenting his speaking on the DCB paclitaxel as a drug of choice, case-driven insights. So over to you, Dr. Nag.
Yeah, thank you. Yeah, so my job is to talk on the benefits of paclitaxel as a drug of choice in drug-coated balloons over sirolimus and its clinical evidence. So we all know drug-coated balloons have revolutionized coronary stenting, and we have gone back to the era when only POBA was used for treating coronary blockages. And now we have completed the circle and are trying to adopt leave behind nothing approach when it was initially started with from Andreas Grunzig. So selecting the right drug for coating these balloons is very important and crucial for maximizing the clinical outcomes. And we all know the two main drugs, anti-cancer drugs used for coating these balloons for anti-proliferative, anti-inflammatory actions are sirolimus and paclitaxel. Most of the data are from paclitaxel-coated balloons, and that is related because of their favorable pharmacokinetic effects. Now, this is a comparison of both the drugs. On your left is paclitaxel, on your right is the sirolimus. So both of them have inherent differences in their properties. Like one is irreversible binding, sirolimus is reversible binding. One is lipophilic, one is hydrophilic. One has moderate positive remodeling characteristics. One has strong anti-proliferative action, and the other has mild anti-inflammatory action. So these basic differences should make some difference in the outcomes, although clinical data do not show any significant difference between both the drugs when they are used in DCBs. So in vitro studies, exposure of smooth muscle cells or endothelial cells to paclitaxel leads to more pronounced dose-dependent growth inhibition than to sirolimus. So these are some of the clinical studies which support paclitaxel, starting from BMS ISR to DES ISR and to even de novo lesion being treated with DCBs coated with paclitaxel. So this is again a preclinical study. These are the biological differences of 3 paclitaxel and 1 sirolimus coated balloons on coronary lesions in rabbit models. Like you can see, comparison between the drug effects and safety of a low dose paclitaxel coated DCB, which were PCB or agent, versus a regular dose PCB, which is Sequent Please Neo, and a sirolimus coated DCB, which was Magic Touch. Now, PCBs or paclitaxel coated balloons showed significant lesser muscle artery ratio than sirolimus coated balloons, indicating high risk of embolization with sirolimus than with paclitaxel. Now, this is a logistic regression analysis of the Eastbourne and the Pearl multicentric studies, in which the primary endpoint was MACE at 1 year. Now, all these patients were around, in the paclitaxel Pearl study was around 513. In the sirolimus Eastbourne registry, it was around 2,000 odd patients. So ISR was around 382 in the paclitaxel group. In the sirolimus group, it was 910. So like you can see, there are no clinical significant differences observed at 1 year follow-up in terms of both of composite clinical endpoints, either in de novo or ISR lesions. So there are some limitations though to consider, not a randomized comparison. These were all registry data, significant variations among the two studies, only partially corrected by the logistic regression model. In the Pearl study, again, the impact of lower P dilatation rates cannot be estimated. So these are again the Picoletto 6 study preliminary results, in which PCB and SCB showed similar late functional loss and late lumen loss with a non-significant trend towards better performance of paclitaxel drug. This is again a RCT transform 1, in which they compared the SCB or the sirolimus drug-coated balloon Magic Touch with the paclitaxel DCB sequent in de novo small vessel coronary disease. Sirolimus failed to demonstrate non-inferiority in comparison to PCB. Again, treatment of coronary de novo lesions by sirolimus or paclitaxel-coated balloon, it was shown that paclitaxel-coated balloon delivered better results in the form of more positive remodeling and more vessel enlargement post-procedure, which was not seen with sirolimus. This was again a drug-coated balloon-only strategy in de novo lesions of large coronary vessels, which were also favorable for paclitaxel-coated balloons. So the drug-coated balloons, angioplasty in large coronary vessels, are we going to do it? Yeah, the future is always a game changer, and these drug-coated balloons may be the future even in de novo lesions in large vessels, even in proximal LAD and left main. So these are comparable with decreased MACE rates and superior angiographic outcomes irrespective of anatomy. The evidence also suggests the drug-coated balloon angioplasty is safe and efficacious for even large vessel coronary artery disease with equivalent long-term mortality equal to drug-eluting stents. So to conclude, regarding coronary paclitaxel DCB, no associated mortality signals were seen or were higher than the DES. There are indications that the therapy could even offer survival advantages in the longer term by avoiding permanent implants or metal jackets. Alternative of sirolimus coated balloon endorsed by many interventional cardiologists still has to prove its clinical efficacy. I will end this with one case of mine, which I did in a patient of 47-year-old male who had extreme high-risk atherosclerotic cardiovascular disease. Why I say this is he underwent first PCI to LAD in 2021, which was done by me for his acute coronary situation. So he's a current smoker, he's diabetic, dyslipidemic, and hypertensive also. So he came back on the September of 2025 with chest pain, and this is what we found. And decided to do, this was the shot in the LAD, which showed minor disease in the distal stent, instant restenosis. We did imaging in this case. For paucity of time, I will not show you all those images. So what we did is we did a DEB in the distal LAD and did a bifurcation stenting of the LCX left main. So this was the final result. Now he went back. He's a hotelier, so he goes back to Gangtok and comes back again after 2 months on the exactly the same day on 5th of November last year, and complains of chest pain. I said, no, we need to look at you again. So this is what he comes back again. So what do we do now? He is already having a bifurcation stent. His LAD, he has a ISR. Now this time we decided to do again a DEB in his LAD because the earlier DEB was done in the distal LAD, which looks absolutely fine so far. And this time we did a lesion preparation with cutting balloon, Wolverine 3.25 into 10, went up to 10 atmospheres. Then we pre-dilated also before that with a NC balloon, and we did a ProTG of 3.520 for 1 minute, 1 whole minute. He tolerated it well, and this was the final result. So far, he is pain-free and he has been on follow-up. He's on all the medications, including evolocumab. Thank you. So that was the case done by me on ProTG.
Nice, Dr. Nag. I think it. Did you consider doing a DEB to the ostial circ lesion when you did
No, I
the
dare
left way
not.
to the circ?
I did not dare to do that because he has been coming back again and again. In fact, my first suggestion to him was to go for a CABG, but he's hell-bent on not doing a CABG. He is a very active man. He wants to go and join his work immediately after his PCI. So he is one person who is not listening to anyone. So after a lot of discussion with our heart team, with the surgeons, and then we said that, okay, this is stentable and we will do that stenting. Yes, I could have done that, but the patients, we are answerable to the patient. Now he has come back to me thrice. I would not want him to come back fourth time just because the ostium of the LCX is very notorious. We all know. Even if I do a cutting balloon, we need to do a cutting balloon there. There is no choice because it is a fibrotic lesion. We have seen that in my imaging. I have done IVUS. So I did not want to, want him to come back. Yes, if he was comfortable saying that, okay, every time I get a chest pain, I'll come back and do an angio, and he stays far away in a remote area in Gangtok, which he runs a few Airbnbs and hotels. So I had to do something for which I
So
would also not lose my
there
sleep.
was a possibility, like there is a possibility in such a
Agreed,
kind of ostial
agreed, agreed,
circumflex lesion that we can think of doing a DEB,
agreed, totally agreed.
especially prepare the lesion well. If there are no
But the
significant
data in
dissections,
left main is very scarce and still not available for left main bifurcation, doing a side branch DEB and a main branch stenting. I mean,
I agree.
I would not go right now into that.
Yeah,
If it's
yeah,
a
I
LED
agree.
diagonal,
But
I
I
would
think
do
in
it.
future, these kind of lesions where you have put a LED stent and then you find that the circumflex, there was some kind of, uh,
Leakage.
residual lesion which you had left at circumflex ostium, and maybe a couple of years down the line, you find that the lesion has progressed. I think there is now a possibility of at least giving it a try to DCB,
Thing
since
is,
we are
he
developing
has
more
very
confidence
aggressive
now with
disease.
the use of DCB
Yeah.
now. So maybe do it. Fine. The stent is always on the shelf. If you, as you said, depending on the patient's profile, the patient's affordability for having coming again and again for the procedures. So that is a possibility which we may see in future, that we do a DEB and see, and if there is no residual dissection, if the end result is good, obviously confirmed by imaging, maybe that is not a bad possibility now. I think once we develop more confidence in the DEBs.
Yes, point well taken. Yeah.
I want to say something. Hi, nice case. So regarding doing a DCB to the osteal circ, whenever we are doing imaging, we can very well image that the disease is confined to the osteal circ only, or if the disease is extending into the LM. If the disease is extending into the LM, then it is a good area, a good thing that you do maybe after trying for a DCB, you do a cutting balloon. If there is no residual stenosis, it is not recoiling back, then you can try. But if the disease is extending into the LM and there's no stent into the LM, then this becomes a case from LM to LCX crossover if we have implanted a osteal LED stent. And second thing, I think looking at the LDL is also very important, because we are repeating a procedure just after 2 months of doing the initial index procedure. And if your imaging tells you that it is NIH, then it is a good idea to prepare the lesion, do the DCB. But if it is a neoatherosclerosis, then what is your take on? Because most of the time, initially it was a class 1 indication, now it is class 2A. So there are in ISR, if you have NIH, you have NAH, or you have a stent fracture, or there are grafts. So for neoatherosclerosis or a stent fracture, I think stent is still the better thing to do as compared to a DCB. So imaging tells us what is the best treatment for this patient at that particular point of time. So this is how we take guidance from imaging once we are dealing with these ISRs. So this is my take on this. And LDL, we have to look at LDL, just keep it below 50 in these patients. I think that is
I
going
think
to
the
help.
disease came back in the LED. It's a very surprising thing that the first time you did the LED stent looked fine, and suddenly, in a very short period of time, you have a new lesion in the LED. That was very
Yeah.
surprising. So nice case. I think we move on to the third case. Dr. Pranay will be speaking on DCP beyond ISR, and he'll be presenting his cases. Over to you, Dr. Pranay.
Okay. Good evening, sir, and good evening, respected panelists. My slides are visible?
Yeah, yeah.
Yeah, okay. So I'll be just showing some case examples, and in the case where we've used DCB as a hybrid approach or upfront DCB techniques, So this is the first case of a 50-year-old female who is a diabetic and hypertensive and comes to us with anginal pain since 2 days, and ECG shows there are STT changes in the anterior lids. So it's an anterior wall MI. So we do an angiogram for the patient. Right coronary is huge, normal, and in the left injection we can see there is total cutoff of the LAD. So the plan here is to go for the LAD. So we wired the LAD first. After dilating with 210 balloon, we got the flow. But now what we see here is the LAD is diffusely diseased from the osteoproximal part of the LAD till the distal LAD. So here what we decided is we do an imaging here. So on taking an imaging run, we can see there is a fibrofatty tissue and there are some dissection over there. So distal LMCA, the lumen area is around 6 square with some plaque there. And if we see the osteal LAD MLA was just 2.2 square with some amount of thrombus over there. So, and we can nicely see that this is a lipid-rich plaque with the thin cap fibroatheneroma, and we can nicely appreciate in the images that there is definitely there is a plaque rupture over there. So that was the proximal part of the LAD was the culprit thing which caused this thing. So what we decided is we stent the proximal to mid LAD first, and for the distal we go ahead with a DCB. So we took a 275 to 28 expedition and then put a stent from the proximal part to the mid part of the LAD, and then overlapped the another stent from left main to LAD, and we established the flow and then tried to optimize it and then took an OCT run again. So now we've got a LMCA area of around 12 square. The osteal LAD MSS is around 6.3 square, and distal part it is around 7.1 and 4.4 square. So now to distal to the stent, there is definitely a significant plaque and the LAD is diffusely diseased. So what we did here is we dilated it initially with 1.5 into 15 balloon and then 2 into 10 cutting balloon, and then we applied a 2.5 into 30 DCB over there, and then we can see the result. The vessel is grown and there is no residual stenosis. The vessel is flowing very nicely, and so the apex we left off because it was very thin. Rest of the thing, the flow has been maintained and patient is doing well. The second case is of the 81-year-old male who is a hypertensive diabetic and comes to us with shortness of breath for 1 week. He's got severe LV dysfunction and there was some STT changes in the anterior lids. Again, his angiogram, it's a diffusely diseased LAD, heavily calcified, and we can see there is flow restriction to the distal part of the LAD. RCA is also diseased. So the plan was to go for the LAD first. So as it was a calcified lesion, we could not get a balloon down there. So we took a 1.25 rota bar to bar it first. So we drilled the lesion and then got some flow over there. So now the thing was to look into the picture what it is. So we initially prepared it with a 2.5 to 10 cutting balloon, and then we took an angiogram and then decided to put a DCB below because the artery was diffusely diseased. So a 2 into 40 DCB was done in the distal part of the LAD, and then proximal part of the LAD was stented with 3 into 38 drug LAD stent, and the overlapped with 3.5. So that is what is the LAD looks like after doing 2 stents and a DCB. So a nice flow and no residual stenosis in the mid to distal part of the LAD. So third case is again a 86-year-old female who comes to us with shortness of breath in heart failure. She's also got degenerative mitral stenosis. So her mean gradients were around 40. So we took her up for angiogram. So again, a severely calcified tortuous arteries. So LCX, there is tight stenosis. In the LAD, we can see there is proximal part heavily calcified artery and a significant lesion over there. And the right coronary artery is a non-dominant artery. So we thought we should go ahead for the LAD and LCX. So as she's a frail lady, old. So we initially thought that we could limit the amount of stent over here. So for the plaque modification here, we took an orbital atherectomy. So we drilled it here. So shaved the lesion in the LAD first, then the LCX. So getting the orbital atherectomy below in the LCX was a challenge because it was a tortuous, but in the slow movement we could get the burr down there and shave the lesion over there. And then this is the IVAS images acquired. So we can see here that there is a huge chunk of calcium, 360 degree of calcification seen, but we have got some lumen gain, but not adequate enough to say that we can go ahead and deploy a stent. And this is for the LCX. The thickness of the calcium is around 1.18. So thick chunk of calcification, and we can see a reverberation artifacts also. So what we did is we took a 3.512 IVL C2 plus and gave the pulses in the LCX and then into the LAD in the proximal part to prepare the to break the calcium nicely. And then again the IVAS runs were repeated. So we can see that the we've got a lumen area which was initially 1.8 after the orbital atherectomy. So we've doubled almost the areas. And in the LED also we've got a good lumen gain. So after doing this, the plan was either we go here for a two stents strategy by doing a DK crush, or we take a DCB into the LCX and go ahead for the LED stenting. So what we did here is we took a DCB 3 into 30 into LCX. So we completed the DCB and there is no residual stenosis and no dissection in the LCX. And LED we completed it with stenting it with two stents. One is 3.532 and 4 into 32 another stent. And this is what is the MSS. We've got a around LMCA was around 22 and then LED ostium 13. The MSS were very good in the LCX also. The lumen area was perfect. So there is no residual stenosis over here. TIMI3 flow. Vessels are flowing well. Patient improved well, and then the plan was to treat her mitral by doing a TMVR. So one more case, which is a 39-year-old female, again presenting with an anterior MI. So her angiogram showing a critical stenosis in the proximal part of the LAD. So when we wired the LAD and pre-dilated it, we also noticed that the diagonal is also a big branch over here, and it is the ostial part of the diagonal is diseased and also mid part of the diagonal is diseased. So we changed our strategy here. So we wired the diagonal. So now we are looking into looking from a single lesion to a bifurcation lesion over here, and either we go here for a two-stent strategy or we do a DCB. So what we did is we initially acquired the OCT for the because she is a young female. We tried to avoid more metal to her. So this is the OCT run, which shows that there is fibrofatty tissue and with some plaque rupture over there and thrombus in it. And the areas again, the distal landing appeared to be around 3 mm. So what, and we also took a run from the diagonal. So diagonal, there was a tight stenosis in the diagonal in the mid part, nice fibrotic lesion. And in the ostial part also, there is tight stenosis. So we can see that the ostial part of the diagonal is also diseased. So what we did here initially is we took a cutting balloon and then cutting balloon into the diagonal and then cut it with a 2 into 13 aperta cutting balloon. So we can see that the lesion appears to be yielded and the residual stenosis doesn't appear to be that much. So what we did is we thought we should go ahead with only single stent strategy. So we stented it on with 3 into 23 into the LAD, and the pinching of the diagonal was noted. So diagonal was recrossed, and after optimizing the LAD, we took a 2 into 12 semi-compliant balloon, opened the struts, and then we coated it with a 2.5 into 30 drug-coated balloon, and again put a 3 into 12 balloon into the LAD and did a kissing balloon inflation. So after doing this thing, we again captured an OCT image. So OCT shows there is a well-opposed stent. There is no edge dissection. areas are good, and the diagonal ostium is strut free. So this is how the final result looks like. So the ostium of the diagonal some haziness, but there is no flow limitation. So we left it alone, and as the drug was coated, she's doing well on 6 months of follow-up. And the last case is again a 57-year-old male who again has a inferior MI. So the angiogram showing a triple vessel disease. So the LAD is totally cut off. LCX, there is tight stenosis in the mid part, and the RCA, there is distal stenosis with thrombus. So we treated the RCA first. So in the first sitting, right coronary was treated with a stent. We achieved a flow. It's a huge vessel. Then we went ahead for the LAD. So LAD took some time to cross. Then we managed to cross it with microcatheter support and a Fielder XTA wire. After crossing it, we initially dilated it, and after dilating the LAD, after achieving some flow, we saw that the LAD is diffusely diseased from the distal part to the proximal part of the LAD. So now the strategy here was to initially prepare the lesion well. So we did a cutting balloon inflation and then acquired an IVUS run. So the mistake here, what we did is we did not go well beyond till the distal part to look into the picture, and we thought only mid part of the LAD is the problem. So we tried to tackle that, and then we stented it with 2 stents, and then after doing the stenting, we noticed that the distal part of the LAD is also diffusely diseased and narrow. So for that, what we did is we again went in and acquired an IVUS image. So IVUS showed that there is significant plaque in the distal part of the LAD. So we can see it just narrows down there. And then we initially cut it, and then we deployed a 2x30 drug coated balloon. And this is the final result, which we can see. The LAD flows well. All vessels are perfusing well. So the patient has done well. So just to end the talk, as technology and technique converge, the drug-coated balloon stands poised to transform PCI from a metal implant era to leave nothing behind philosophy. This is how we redefine the vessel healing for the next generation. Thank you, and I'll keep the forum open for discussion.
I think all the cases were very challenging and very beautifully done. So it basically gives us an idea how a hybrid or a combined strategy can help us, stand along with DCB. So to minimize, not only to minimize the amount of metal which we are putting in, but to also minimize the higher chances of instant restenosis in the future. Only thing is that what you showed that the patient with metal stenosis, where you had a very calcified and tortuous circumflex. What I've also noticed that when you have very tortuous vessels, which may not be calcified, but you have tortuous vessels, sometimes we are tempted to put a stent, and a lot of times we get edge dissections, which are not seen unless we do a proper imaging. So I think in these kind of tortuous lesions also, a DCB has got a good application.
Yeah.
Where you have, almost 70-degree or 90-degree tortuosity, instead of trying to put a stent and trying to artificially straighten the artery and, deforming the artery and changing the anatomy of the natural curve of the vessel, I think it is always a good idea that you think of a drug-coated balloon. If you get a good result, you can not only avoid a stent, you can also avoid disturbing the natural anatomy and the natural curve of the vessel. I think most of the cases were extremely good. I think heavily calcified vessels, you were very brave enough to, because usually drug-coated balloons are slightly bulkier compared to non-compliant balloons. So a good amount of, the vessel preparation is very necessary. Very necessary. Extremely good cases. Anybody wants to add anything?
Nice. Sometimes we need guide extension catheters to deliver these DCBs along the tortuosities. And one thing more I noticed that you have mentioned Aperta as a cutting balloon. It is a scoring balloon by Nepro. It is a scoring balloon with a nylon blades. Yeah. With a very good profile and very good reusability profile in our
That's very
patient.
important, I think, reusability.
Yes. Yes.
I think we'll move to the next case, role of DCB in small branches and sign vessels by Dr. Nirmal. As Dr. Nirmal, he has joined us. Fine.
Sorry,
Nirmal, welcome. And I
respected
think we'll
sir
start with your.
and colleagues.
Yeah,
Actually, I got stuck in a PAMI, so I just got late.
no
Right now,
problem. No,
I'm
we
in.
understand. We understand.
Yeah, yeah.
A fellow
So
Ahmedabadi.
actually,
So
my
please
HUL ID that my
start your
clinic,
talk.
right now I am at my hospital's OPD, but still I'll have some.
Yeah, yeah.
Can you?
Try to make it short and sweet so that
Yeah,
you
yeah.
can leave on
I'll
time.
just keep it. Slides are visible.
Yeah, yeah.
Okay. So right now, just a minute. Mhm. Oh, I think my slides are not visible right now, right? I just have to.
We can see, but you have to just go to
Okay,
the
fine.
PPT mode.
Okay, yeah, I am
Yeah,
on
fine.
PPT mode, but just my, uh, I don't know how to.
So
The
if you
next
say
one.
I can share up your slides, sir.
Yeah, 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 yeah. Please,
Okay, I'll just do that, sir.
because I'm not used to this laptop, so I think I'm so confused.
Sir, kindly unshare the slides.
Okay.
So still your screen is visible, sir. Kindly unshare the screen.
Right now, it's I think
I'll do
still
that.
it's been.
No, it has been done by me. 1 second, sir. Sir, hope my screen is visible.
Yeah. Yes. Yes. Can you just put on this slide? Yeah. Okay, so actually, I won't be able to show the images here because I'm from some other laptop. So it's a straightforward case, like 68-year-old male patient, known case of diabetes, uncontrolled, and hypertension for more than 15 years, and had history of ischemic heart disease and was CAD DVD with fair LV function, and patient had undergone PCI to ILD and SIRC in 2022. Patient had history of GI bleed with severe anemia with HbF around 8 last year, and now patient presented with typical anginas on and off since last 2 months, and patient was in NYHA grade 2 to 3. Next. Yeah, so check angio was done. LAD was suggestive of well-flowing stent, but it was followed by 90% lesion in mid and distal LAD, which was small caliber vessel around 2 to 2.5 to 2.5 mm angiographically. Because of financial constraint, we could not do any imaging. Sir, stent was also well-flowing and RCA had no any significant disease. Next. So challenges in these cases where there's a small vessel coronary artery disease, significant disease and symptomatic. Patient had uncontrolled diabetic with HbA1c of 12, and high chances of ISR in this case. And patient also had history of GI bleeding with severe anemia. So again, there is a high risk of giving ticagrelor along with the aspirin in this particular case. So these were the challenges. So we next please. So considering all risk factors, we decided to go ahead with the DEB in this case. So post-wiring pre-dilatation was done with the 2 2 × 15 NC balloon and followed by 2.520 NC balloon. Followed by we took a DEB of 2.530 mm, and it was done for around 45 seconds. And there was no dissection, very good flow and expansion, and there was TME3 flow distally. So patient was discharged on aspirin and clopidogrel, and patient is still in follow-up after 3 months, and patient is completely asymptomatic. Next, please. So there was always a dilemma. So what is actually a small vessel? So definition of small vessel is inconsistent across all the trials. There was all small vessel studies. They range it from 2.25 to 3 mm. And the main ISR Smart trial had defined it as a reference diameter of less than 2.8 as a small vessel. Right. So in current practice, very small vessel, we label it as if it is a diameter is of somewhere around less than 2.25. Next. So small vessel disease is commonly associated with female sex, old age, diabetic patient, associated peripheral arterial disease, and long lesions. Next. So clinical impact of small vessel CAD is first is there is a lack of any standardized definition as just we discussed about the size. Second thing, only majority times when the patient has a distal small vessel disease, also have this concomitant proximal disease. But wherein patient with small coronary artery disease, proximal segments are virtually always involved. It's other way around. Third is the amount of the myocardial tributary of affected vessel is directly related to the vessel diameter and its length. Next. And fourth is that many a times we don't have imaging help of imaging. So many times we just angiographically define is that is a small vessel. So it often gets underestimated. Next. So far, if we see in the past and future, we had started with the balloon angioplasty and metal stents, followed by first generation DASH, followed by second and advanced DASH. Now we are in era of DEB, and also we are evolving over the years. And there are so many things under studies right now. Next. So if you see the slides, the major trials so far for small vessel coronary artery disease. First trial is that basket small 2 and bellow trials. They took coronary arteries with the diameter of less than 3 mm. The basket small trial was head-to-head comparison between DAS and DEB, and it showed the non-inferiority of drug-coated balloon over the DASH. So there was the Bello trial. In Bello trial, they compared the DAS versus the this DEB with paclitaxel luting a balloon, right? So this trial showed that DEB can give drug-coated balloon can give you a optimal results, which is non-inferior and long-term good results. So next trials were Picoletto 1 and 2. So in Picoletto 1, the reference vessel diameter was less than 2.75. In trial 1, they had taken the generation 1 of drug-coated balloons, and they showed that if you see the TLR and TVR and this MI rates, they were quite high. So they found that the technology has to be evolved, and when the trial the Spicolator 2 was done with second generation drug coated balloon, and it showed a very good results with significantly reduced rates of TLR and myocardial infarction. So technically advanced drug coated balloon can give you the optimal result, long term lesser chances of target vessel restenosis or target vessel revascularization and subsequent MI. And this restored SVD trial was a landmark trial, which was also they had very good results with all the TLR, TVR, TLF, and MI rates were very less. So it was clear cut that they confirmed this trial confirmed that the DEB has a significant role in small vessel diseases, and we can achieve optimal results and which were non-inferior to drug-eluting stents. And last trial was by Vecchilaro et al. And they did this study with average RVD around 1.95, and they also got the good results with the TLR of around 3% and MI rates around 1%. So by and large, all the trials had promising results as far as the drug-coated balloons concerned. So these were the clinical data. Next slide. The same slide. This is just a revision of the last slide. Can you just next? So again, last slide please. So treatment option for side branch as well as along with the small vessel SVD, drug coated balloon also has a promising results in bifurcation lesion. So it can reduce the risk of stent thrombosis, reduce risk of progression, and better angiographic and clinical outcomes. And always there are the reduced target lesion revascularization. Next, please. So there are some clinical data when they compared compare the drug-coated balloon in side branch for de novo bifurcation lesion, and they had promising results. Next slide, please. Next slide. Yes, this is the restore trial which we just discussed with all comparative data suggestive of promising results and non-inferiority when compared with the DES. Next, please. Okay, so Picoletto trial 2 also, as we can see, the TLR and MACE rate were comparatively low as compared to DES at the 3 years of follow. Next. Again, the drug-coated balloon for bifurcation lesion also has the less chances of restenosis and MACE event. compared to the this thing. Right. Next. So take home message here is the drug-coated balloon is now evidence-based therapy for small vessel coronary artery disease as well as with bifurcation lesions. So outcomes are comparable and non-inferior to DASH, and best results seen with proper bed preparation, modern new generation drug-coated balloons, and with reference vessel diameter in range of 2.25 to 2.75 mm. So better it avoids the permanent implants, reduce the long-term vessel impairment, and they are more useful when there is a diffuse disease, long-term uncontrolled diabetic patient, high-risk bleeding patient, as in my case. So young patients, when you don't want to give a very long-term high DAPT, and of course the small vessels, very small vessels. I think I'll end my talk here, and it's a small presentation. Thank you for listening me, and
I
anything.
think message well taken, Nirmal, that small vessels are now, especially as I have said in the beginning, Asian countries, Indians, we have, long-standing diabetic patients normally have diffuse small vessel disease. Side branches are no wonder they are extremely diseased, but we find mid to distal vessels. And as you rightly said, what do we label as small diameter? Now, with the expanding use of the depth, now I
Imaging
think the
also.
vessel diameter has not become very relevant now. It is more about how good vessel preparation can you do
Exactly.
with your non-compliant or a
Fancy
semi-compliant balloon.
balloon. Yes.
If you are able to get a good vessel preparation, no dissections, no flow limitation, no symptoms, no ECG changes, I think drug-eluting balloons should be given a chance, especially in young patients. I would say that,
Agreed.
avoid metal as much as possible. Can you give me some idea about your experience? Suppose, see, like we have all started using the drug-eluting balloons recently. Any of the participants, if you can give me an idea, suppose you have a case of primary angioplasty where you have, already the vessel has started flowing, patient is stable. You do an angiogram, you find triple vessel disease, patient has to go for a CABG. But you are afraid that the vessel may close in the middle of the night, maybe on the same day or the next day, or subsequent couple of days. So in those kind of cases, have you ever thought of doing a DCB in the culprit lesion?
So the only
Yeah.
problem is that when you are doing a primary, there's a lot of thrombus, and it is said in presence of thrombus, DCB doesn't work. So
Yes.
if you are thinking of keeping this vessel open, I think just doing a maybe plain balloon if a patient is going for a CABG another 2-3 days. I mean, this is my take on. Otherwise, one can try doing this, but if a patient is going for this thing, then how DCB is going to help this patient, I really don't know.
So
Yeah.
maybe I
I
think
think plain
that
balloon can save the cost also for the subsequent CBG. I
Yep.
think just do a
yeah,
plain balloon.
Yes.
sir, if the flow
I
is
had a
well
patient
and
yesterday. Yeah, please go ahead. Sorry.
if the
Yeah.
flow is well and if it is a Timmy 3 flow, we can comfortably let it be there, and maybe a GP2B3A might help to keep it patent. And unnecessary fiddling the artery, we might land up having a problem and then end up putting a stent in another way. If you suppose we do a POBA or we take a DCB over there and then get a dissection and then we'll end up putting a stent over there. So better if we have a good flow. I personally do if it is I want to send a patient for this thing. I start upon GP2B and a Nicoran infusion and then take the case in the morning for bypass unless it is loaded with antiplatelets.
How
Okay.
frequently have you
Right.
seen this, low platelet counts, low hemoglobin levels, history of bleeding piles, and then you are, tempted to put a stent versus a DCB? What are your experiences in such patients? High bleeding risk, frail
I
So sir,
patients.
Then you are
now
justified doing this.
So I would like to discuss one case here. Recently, just 1 month back, I had one patient. He's a 78-year male patient, known case of CA lung. He was undergoing the chemo, and patient had N-STEMI post chemo 2 cycles. So there was significantly raised tropi. BNP was around 3000, and there was significant ST depressions on ECG. LV function was good, so I did an angio, and it was suggestive of proximal LAD was 80%, around 80 to 90%. So considering the case of CA lung, high chances of hemostasis in future, with all provided normal LV function and flowing vessel. So I did a DEB in this case. After 2 months of this therapy, patient is I put because I put the patient on aspirin and clopidogrel 75 for was 1 month, and at I think 3 months down 2 months down the line, patient is back on chemo. He has already undergone 2 cycle, no symptoms, doing absolutely fine. So I think in those set of case where you want to give it as a high risk of bleeding, chances of anemia or any such adverse events are there, then you can always consider DAB over putting a stent. Like I took the decision for the same reason in this
Is there
particular case.
any consensus amongst you all about use of dual antiplatelet after a DEB or a single antiplatelet? And if dual antiplatelet, for how long before you switch the patient to a single antiplatelet? Any ideas?
So for ACS, you have
3
to go by
months.
the guidelines of ACS. It is a DAPT for 12 months, unless and until you have a high bleeding in this patient.
Yeah.
For stable angina patients, if your patient has a high bleeding risk, after 1 month, you can try and switch it to SAPT. So that's.
And we'll come to the last presentation now by Dr. Preeti, who will be talking about the hybrid approach. I think, Preeti, you can start immediately now.
I'm not giving a lecture. I'm just sharing one
Sure, please
case.
do that. That is
Yeah.
most useful, I think. Yeah.
Yeah. So just I encountered this. So I hope my slides are visible. So I'm sharing this case, which we did some 6 months back, maybe. This was LMISR in post-DVR patient. So just look at this history. He's just a 58-year-old male, hypertensive diabetic, and he has undergone DVR in 2019 at our center only. And currently, he is on oral anticoagulation. I did his LM2 LED plasty in 2019 because that time our surgeon thought that he's a high risk patient if we consider DVR along with the CABG. He had LED disease. So we fixed LM2 LED at that particular moment. And then he had undergone at our center only post iliofemoral graft in 2021. Now, in 2025, he had presented with chest pain on minimal exertion for 3 days. This time, there are deep T inversions in precordial leads, and ejection fraction, which was normal, is now 40%. And he has nephropathy with the creatinine clearance of 50 ml per minute. So this is the angiogram did initially with the radial route. As you can see that the tiger is not sitting well. That time I realized that we have something like hanging struts of left main into the aorta. And these are the pictures I got that day. So LED is having, so it is LM2 LED stand, and there is some ISR into the osteoproximal LED and at the ostia of circ. So this is the iliocaudal view. We can all appreciate the same in this, and the RCA was nice. There was no lesion in the RCA. So once I saw this, my initial thoughts and discussion, the syntax score was 16. And we know that the special consideration is that this patient is a high bleeding risk patient. And this is an ISR, LED as well as ostial circ, again discussed with my surgeon and then planned for a PTCA. Now in my mind, I'm open for maybe a hybrid, maybe both DCB or DES based on plaque preparation. This was the idea with which I went in for this case. And he's on oral anticoagulation. So first thing was I had to take a 7F guide. It is a femoral puncture. And we did an ultrasound guided puncture. And I tried EBU 3.5, EBU 3. And then this was a JL4, femoral JL4, which was sitting like this. Now, if your guide is sitting like this, the only challenge is that once you're wiring, your initial wire might cross through the LM struts and you might deform the LM struts which are hanging into the aorta. So the first thing if you pass wire, just see that you are having some kind of resistance or your guide is coming closure if you're pulling a wire. So these are the maneuvers I tried, and I thought maybe I am through the proper channel. This was the Xion Blue and BMW, Xion Blue in LED, BMW in LCX. So this is how the balloon was going initially, like this. So this is the 215 balloon into the circ, then into the LED, then a 25 balloon. And then I did a IVUS pullback this was from LED. And this was a well opposed. That time I did not do any imaging, but this was a well opposed stent, and you can see that the tissue growth looks like a mixed kind of a growth, but more of intima hyperplasia. There is no clot or anything. And then as we move to the LM, looks okay. LM is okay, the area is okay, and there is no tissue growth inside the LM. So LM is good here, mild tissue growth into the LM. So these are the hanging struts. This is the previous stent into the LAD. Now this is the pullback from LCX. We will notice some important thing. So this is a huge LCX, as we can see, 4-row. And as we move forward, this is the branch, some branch coming inside, and there's some. So this is the, if I may, so there was a kind of a strut of a stent coming over there, which I have shown here. And this is after dilatation with a 2.5 balloon. And then subsequently, I thought maybe I should crack it. Maybe I should make some space with a bigger balloon. I then dilated this with a 3 and then subsequently with 3.5. And then I did 3.5 kissing balloon on both the sides, keeping both the balloons. I did a 3.5. And this was the image I got after the 3.5 kissing balloon dilatation into the LED and LCX. Looked okay. I thought maybe this is the time I can take my DCBs and then subsequently apply it and then do a kissing balloon. But this was the LAO caudal view where I could see that the LCX ostia is still looking hazy. And I knew that there is something which is protruding into the LCX ostia. So at that moment, I changed my strategy to a culotte one, took a 3.5/18 stent from LM to LCX. So this is a stent. This is how it is deployed, well expansion. And then we did a pot with a 4.56 balloon into the LM. Post this, LED was recrossed and then dilatation with the 2.53 and then a 4.20 paclitaxel coated DCB into the LAD. And this is the kissing balloon after that, and then again a repot, and then this is the result we have got after this. We did an IVUS post, final IVUS from LED. And my only idea was just to see whether there is no residual stenosis or anything there, which will maybe bring this patient back on the table after having so many procedures. But thankfully, it looked okay, and we could achieve the magic numbers, which are actually. So this is the part where we had a tissue growth. There's a reasonable maybe expansion of the lumen with no residual stenosis. And this is the circ coming in. And this is the IVUS from the LCX pullback. And as we move forward, we can see that this is a well expanded stent. There is no distal dissection. And as we move to the LED, we can see that our carina is free of any metal. So this is a double layer of a stent as you expect in a culotte. And this is the point where the LED is coming in, good expansion. And 12 in LM and then maybe 9 or 10 in the LCX. So LMISR, so take home message. So LMISR, the alternative strategies are maybe you can these patients go for a CABG or maybe repeat stenting. So this patient, as he's a high bleed risk patient, we were trying for a both DCB approach, but as the lesion preparation in LCX we thought was not optimal, we went in for a changing LM to LED crossover to a culotte strategy. And then for LED, we opted for a DCB into the LED as we could achieve a good expansion with a cutting balloon and post NC balloon dilatation. And once you have these hanging struts, which more and more I see now, realizing that their wire entries into the true stent lumen is very important before you take any of your devices or any of your imaging catheter across these hanging struts into the left wing. Thank you.
Good, nice, careful approach. So after you did the kissing balloon, one was a non-compliant balloon in the circ and your DCB in the LED.
No. I did both
But
NC balloon
after
after
DCB,
this.
do you normally recommend to put an NC balloon once you have done a DCB? Do you
So
normally
while
do
I
it?
was while I was planning to do this case, I had gone through multiple studies and I have seen many lectures. And they say that after doing, so it is not recommended to do a kissing balloon with one DCB and one NC because both have different
Agreed.
profiles. And
Agreed.
here, what you are trying to do with the kissing balloon is to keep your carina in the center.
You
So
can't go high
kissing should
pressure with your
always
DCB.
be with the NC balloon. So I
Agreed.
tried and searched literature, and then I could find that if you are doing these cases, doing maybe kissing balloon at 6 to 8 atmosphere there is not going to distort your metal, your drug from there, and you are able to achieve a good carina into the center. So this is what I could find in the literature. Obviously, these are new things to
Yeah.
come up. We will have more and more literature in coming times. Nobody is sure that what to do, and they say that you should not be doing kissing with the two DCBs keeping there. So this is also one thing which I could find out, that we should try avoiding doing kissing balloon with the DCBs at the bifurcation. So
Could
that's
we have
how.
done that? First, we do both the NC balloons, we do kissing, and then after that, we do, in the second instance, we could have used the DCB.
So I for most of the if bifurcation lesions, once you so it is a true bifurcation lesion with the angle maybe I will say 70 degree or less. So once you dilate one vessel, the carina is going to shift to the other, and you will see pinching of the other. So if you want to dilate these two vessels and you want to have a good result, you have to have a kissing balloon dilatation. Then only you can see that you have done a good
That
preparation.
I agree that
Otherwise,
instead of
this
doing a DCB first and then a non-compliant balloon, we could have done the kissing balloon with do two non-compliant balloons, the kissing, and then switched over
then do a sequential
DCB.
DCB.
Yes.
You are saying that again you are doing the same
Yeah, I
thing.
agree. But then
You're
it is not followed
yeah.
up by a NC balloon again.
So in LADD even I can think of this, but in an LM situation with a stent over there, I mean I was not confident with keeping
Yeah,
carina like this
even
towards
if at
LAD.
low pressures or DCB, you can distort the circumflex
Yeah,
stent.
yeah.
So fine.
Thank you.
We come to the end of all the lectures. I think it was very informative, and we had some kind of, we are all learning about DCBs.
Yeah.
It's relatively new for all of us, and we are, gradually finding our mojo, like, where to use, where not to use, different things. Anybody wants to add anything at the end of the lecture now? Any inputs, anything from any of the participants? Right. Good. Anything from your side, Garima?
So, sir, I would just like to thank all our faculty members today for dedicating your time and efforts to share up this knowledge and informative knowledge to all our community in interventional cardiology, and sharing up the insights on drug-coated balloons. So, thank you so
Yeah.
much to all our faculty, and I hope we will be collaborating very very soon in the future as well.
Yeah.
Thank you.
Thank you all the
Thank you so much,
participants.
and
Thank
have
you
a
for
great
giving
good
us
night.
your time.
Yeah,
And thank you, Garima. Thank you,
thank you
Transluminal
so
team.
much. Thank you.
Thank you.
Thank you, everyone. Thank you.
Thanks.